Good evening, everyone. We will be discussing about mechanical ventilation basics. We'll understand we use in a day-to-day basis, especially in our ICUs, a lot of ventilator modes. A lot of the patients, especially COPD patients and ARDS patients, pulmonary edema patients, a lot of the patients require mechanical ventilation. So here we'll be discussing on the various kinds of mechanical ventilation modes. What is NIV, what is invasive ventilation, what is volume control, what is pressure control and all, and also what are the settings we need to in the different kinds of setting, different kinds of diseases we'll learn in this. So before going into the discussion, this is a screen that scares us a lot, how to change all these settings, what are these all the loops and all. So first thing, this is the volume control which we commonly use in our day-to-day practice. So first thing, this is oxygen concentration, this is FiO2, how much you want to deliver. So this FiO2 can be ranging from 21 to 100. 21 is room air, to 100 is the maximum you can deliver. So any increase in the FiO2 will increase the oxygenation. Like if there is SpO2 low, you can increase the FiO2, so it will increase the oxygenation. So this is the positive end expiratory pressure, PEEP. So PEEP is generally kept at a minimal of 5. It can be increased based on the patient requirement. If the patient is obese, you can increase to 12, 14 also. But basically you start at 5, increase incremental value of 2, you can increase. So PEEP is also like oxygen concentration, or like FiO2. It will increase the oxygenation capacity of the lung. So what is PEEP is? PEEP is a positive end expiratory pressure. So it will keep the alveoli open so that more oxygen can be delivered, so that better oxygenation can be saved. So we can get. So FiO2 and PEEP, with increase in the FiO2 and PEEP, we can get increase in the oxygenation. So that is better SpO2. So this is respiratory rate. So respiratory rate can vary based on the patient requirement. The patient is already taking PEEP, you might need to put in the more respiratory rate, but generally we will put around 14 to 16 or something. So based on the, it also depends on the disease. So this is respiratory rate. This is the amount of respiratory rate the ventilator has to deliver. And tidal volume we generally keep around 6 to 8 ml per kg, especially in ARDS. That is ideal body weight. So how do you calculate ideal body weight? You can let me know. You find it out and let me know. But both this respiratory rate and tidal volume will help us in the washing out of CO2 from the body, especially in the case of COPD patients where the CO2 retention is there. If you increase the respiratory rate, it will cause a more CO2 washout. And also if you increase the tidal volume, more CO2 washout will be there. So these both parameters will help in the changing of the CO2 washout. So FiO2 and PEEP will increase in the oxygenation capacity, and increase in respiratory rate and tidal volume will help in the CO2 washout. So what are the other parameters? There is a P peak, there is a P plateau, there is a P mean and P. PEEP is already been mentioned. There is a respiratory rate and also a I by E ratio. There is a IE ratio. There are many. This is tidal volume. This is how much of tidal volume is being delivered into the lungs. So this tidal volume inspiratory, tidal volume expiratory. How much is going in, how much is coming out. So this will help us in understanding the different parameters. So we did discuss P peak. So generally P peak is the peak that is attained during the pressure delivery. So generally increase in the P peak is what will tell is anything P peak around 35 to 40, it is more than that. It suggests that there is a kinking of tube, any upper airway obstruction that can be due to tracheal, that is tube blockade, or any kinking of the tube, or any bronchoconstriction, especially upper airways. So if the upper airways are blocked, that can be due to kinking or tracheal obstruction, any mucus plug that is blocking the ET tube or anything. So that will increase the P peak. So what is the P plateau? So this is the P plateau. Whatever P plateau is that, this is the P plateau. So P plateau will increase in the any obstruction in the lung level, that is due to the alveolar incompliance or any decrease in the elasticity of the lung, compliance of the lung, that can be due to ARDS or pulmonary edema or fibrosis, anything. So this P peak and P plateau will tell about the different ways where the obstruction is happening. So P peak will tell you about the obstruction at the upper airways, especially trachea, bronchi, especially if there is a chronic bronchitis or asthma, it will cause bronchospasm. That will increase the P peak. So any mucus plug, any tracheal blockade, or any kinking of the tube, that will increase the P peak, especially in the upper airways. The P plateau will tell about the compliance of the lung. That can be increased, that can be compliance, that is dilation of the alveoli can be decreased in ARDS, pulmonary edema, any fibrosis. So P plateau will be increasing those parameters. What is I by E ratio? Generally I by ratio is the inspiration to expiration, like how much time inspiration is happening, how much time expiration is happening. So generally expiration is more prolonged when compared to inspiration in the normal respiratory cycle. Generally I by E ratio is 1:2. So you give enough time for expiration of the whatever tidal volume you have inhaled. So generally I by E ratio is generally like let's say I by ratio is generally 1:2. You made it 1:1 or 1:1.5. So what will happen? Inspiration time is increasing and expiration time is decreasing. So that is 1:1.5 or 1. So both are becoming equal. So in them inspiration time is increasing. So generally I by E ratio is like 1:1 or 1:1.5 is made in the case of ARDS, where you want to increase the oxygenation. If you increase the inspiration time, increase the oxygenation. So generally routinely we keep in the 1:2 ratio only, but if the patient is having increasing requiring higher amount of oxygenation, then we can decrease the to 1:1.5 or 1:1. So in them expiration time is decreased and inspiration time is increased, so that better oxidation will happen. But the problem with this, if you decrease the expiration, it won't give enough time. Like if you decrease the I by ratio to 1:1 or something, it won't give enough time for the whatever tidal volume inhaled to get out of the lung. Expiration time is decreased. So what will happen? Some amount of tidal volume is retained in the alveoli itself, because we didn't give enough time for the lungs to exhale. So it will generate the auto PEEP, that is some amount of volume is retained inside the lungs at the end of inspiration, because we didn't give enough time for the expiration. So it will generate it will cause a volume retention at the end of expiration before the next breath is taken. So this generate auto PEEP. So whatever volume is retained because of the insufficient expiration will generate a pressure inside the alveoli, that is called auto PEEP. So this is generally commonly seen in the case of inverse ventilation, where we increase the inspiration and decrease the expiration, or COPD patient, because in COPD patient, because of the obstruction in the expiratory pathway, because air can't be expirated completely. So in them auto PEEP can be seen. We will discuss about auto PEEP in the further chapters, in the further slides. So why do we need ventilation per se? So we basically understood all the thing: FiO2 PEEP for increased oxygenation, respiratory tidal volume, especially in the case of CO2 washout. What is PPK, especially upper airway obstruction, P plateau, especially in the case of any lung compliance problem. I by ratio is generally 1:2. If you decrease, like we made it almost inspiration expiration equal, like 1:1 or 1:1.5, it increases the oxygenation, but it causes auto PEEP also. So where all we use the different kinds of ventilators, where do we use ventilator, especially when there is a loss of airway anatomy, like when there is edema or infection or some pulmonary embolism, and there is insufficient oxygenation to the blood, and also when there is a loss of protected airway, especially in the case of stroke or any intoxication or altered sensorium we use, or when there is inability to ventilate properly, especially in the case of respiratory muscle paralysis, especially in the case of GBS or amyotrophic lateral sclerosis. So these are all the conditions where we use. If there is a lung pathology, or if you are not able to oxygenate properly, if there is a altered sensorium per se, or if there is a respiratory muscle paralysis, in all of these cases you use. So what is the step? So you need to pick up what kind of ventilator setting you need to use. So there is a volume control, there is pressure control. So if you have a volume goals, let's say you want to you want to deliver a set volume, tidal volume. You want to send a tidal volume of 400 ml, definitely. So use volume control. In them, the tidal volume what you want to set is already set, like 380 ml or 400 ml you set. So no matter what amount of pressure that requires to deliver the tidal volume, it will be delivered. So in the volume control, you set a tidal volume which will be delivered. So it's volume cycled, it's volume assist, and it's volume limited. So whatever your tidal volume is set, that is delivered. In the case of pressure goal, pressure targeted, like you set a certain amount of pressure, let's say 14 centimeters. So till that 14 centimeter, how much amount of tidal volume it can deliver? It can be 200, it is 300, it can be 400, it can vary. The tidal volume can vary, but the pressure what you are set at 16 or 14, whatever pressure you set, till that pressure is generated, how much amount of tidal volume it can generate, it will deliver. So, but it varies from breath to breath. Sometimes it can deliver 200, it can deliver 300, it can deliver 400 also. So it varies, tidal volume varies, but pressure is fixed in the case of pressure control. So most of the patients in adult ICUs use generally volume targeted, especially in the case of pediatric ICU use pressure targeted. Because in pediatric ICU there is a risk of barotrauma. That's why we limit the pressure whatever we are delivering. That is why in pediatric ICUs you use the pressure targeted. In the most of the adult ICUs we use a volume control. So this is the pressure targeted, where you generate this is pressure support, whatever pressure support. This is the inspiratory pressure, this is the inspiratory pressure, this is the end expiratory pressure. So at the end of expiration, this is the positive end expiratory pressure. So this is to keep the alveoli inflated. So this is the pressure inspiratory pressure. This is the amount of inspiratory pressure that is being delivered. Whatever difference that is there is called pressure support. So inspiratory pressure, expiratory pressure, the difference is pressure support. This is the principle behind the BiPAP mainly. In non-invasive ventilation, this is the principle behind. So we generate inspiratory pressure, we generate expiratory pressure, whatever difference that is pressure support. This is useful in the case of COPD patient, OSA patient, where we want to oxygenate them better and wash out the CO2 better. So how does the different modes of ventilation? There are different modes of ventilation, especially assist control is there. There's synchronized intermittent mandatory ventilation. So generally, what is the difference between assist control and intermittent mandatory ventilation is? So in general assist control, let's say every breath whatever you are taking is supported by the ventilator, whether you take it spontaneously or whether it is delivered by ventilator. Whatever you are taking, it is supported by the ventilator. Whatever in the case of synchronized intermittent mandatory ventilation, let's say patient is taking breath spontaneously, and let's say you set a rate of 12 or 14 breaths per minute. So let the patient is taking more than that. Let's say patient is breathing at 20 breaths per minute. Whatever the 14 breaths per minute, if they are overlapping with the intermittent ventilation, it is supported by the ventilator. Whatever the 6 extra, what is he taking in between the mandatory ventilation, it is not supported by ventilator, and they should be whatever patient effort is there, he will take on that. So there is a risk of hypoventilation in the intermittent breaths in the synchronized intermittent mandatory ventilation. Wherever every breath, whether the patient is taking that or whether the ventilator is supporting that, it is mandatory ventilation, every breath is supported by the ventilator in the case of assist control. Whereas in the case of synchronized intermittent mandatory ventilation, only breaths which are occurring during the intermittent mandatory phase, so those are only supported by ventilator. Whatever breaths that are occurring in between, which are generated by its patient, is not supported by ventilator. It is completely dependent on the patient's effort. So this is difference between the assist control and synchronized intermittent mandatory ventilation. So generally, what is the difference between the assist control and synchronized intermittent ventilation? Let's say patient is paralyzed, so he can't generate any spontaneous breaths. So let whatever fixed rate, let 16 breaths per minute, whatever you keep it, that will be delivered. So in assist control or SMV doesn't matter in this, because whatever set rate you are setting, they'll be completely supported by the ventilator in both assist control and synchronized intermittent mandatory ventilation. Let's say patient is conscious and all, he's not paralyzed, but patient is generating less breaths when compared to intermittent whatever set rate you are getting. In them also AC and SIMV will look exactly the same, because patient is breathing less than the whatever set rate you are using. So all of those breaths will be supported by the ventilator in AC mode and synchronized intermittent mandatory ventilation. Let's say patient is breathing faster than the set rate. So let's say you kept a set rate of 16. In the case of but patient is breathing at more than like 24 or something. In that assist control, what will happen? Every breath, if 24 breaths will be supported by the ventilator, though the set rate is at 16 only. But in the case of synchronized intermittent mandatory ventilation, only that set rate will be supported by the ventilator. Remaining extra 8 breaths is the patient's effort. So that is the difference between the assist control and synchronized intermittent mandatory ventilation, where assist control every breath, beyond the set rate also it will support, whereas in the case of synchronized intermittent mandatory ventilation, only whatever set rate is there, it will be supported by ventilator. Extra breaths should be under the patient's effort only. But this might lead to the respiratory fatigue and also hypoventilation sometimes. So that is the difference. So this is the volume control, everything will be supported by the ventilation, whereas in the case of synchronized intermittent mandatory ventilation, only mandatory ventilations are supported by ventilator and remaining are completely dependent on the patient's breath. So these are the different. So where do we use assist control, where you use SIMV? So generally any patient that is non-conscious on initial stages of ventilation, so like you just started patient on, you just intubated the patient or something, you start them on assist control ventilation. When the patient is slowly becoming conscious and all, so then you start them on synchronized intermittent mandatory ventilation. Slowly you wean them and put them on the CPAP support or pressure support ventilation in the end stage, and then wean them off. So initially any patient are non-conscious or something, or patient is initially started on ventilation, you put them on assist control. Slowly, if the patient is able to take spontaneous breaths and if his respiratory capacity is good, because if the respiratory capacity is not good, this breath whatever is generated, it won't be good enough to ventilate the lungs properly. So only when the patient is conscious enough and the patient is able to generate enough respiratory capacity, and like there is no muscle fatigue or nothing, slowly he was able to generate enough pressure to generate the breath, then you convert to SIMV and slowly and you change it to pressure support ventilation, that is a CPAP or something, then slowly wean off, put them on TPs and wean off. So but you need to put them on SIMV so that the patient's muscles won't go into fatigue or something. If you put them continuously on assist control ventilation only, the respiratory muscles doesn't require any effort, so the patient mechanical ventilator will continuously deliver oxygen, so respiratory muscle atrophy like paralysis will occur. So that's why after 2-3 hours or something, you need to put them on SIMV, check how much patient is able to generate breaths and all, how much respiratory muscle is able to put an effort to generate the breath. If the patient is able to generate good amount of effort, that is good, continue on SIMV. If the patient is still not able to generate this, there is some lung infection or something, if the patient is not able to completely generate, convert it to assist control again, and check again after 4 to 6 hours. If the patient is able to generate enough muscle power, respiratory muscle and all, if generate respiratory muscle, convert it to SIMV. If the patient is doing well, continue on SIMV. So this is the pressure support. So patient is generally, let's say this is after SIMV, the patient is generally spontaneously breathing and his respiratory effort is all good. Just you need to support that extra effort, so that you need to give a minimal support. Then just before weaning off, you use pressure support ventilation in the case of invasive ventilation. So this is the pressure support. In the pressure support ventilation, what we just set FiO2 and PEEP. So FiO2 is the oxygenation, PEEP is the to keep the alveoli inflated, so that it will decrease the respiratory effort that needs to be put by the patient. So this is just done just before weaning of the ventilator. So this is generally in the case of good choice for the intact mental state with airway issue and unable to tolerate the ET tube, and patient those with sedatives and intoxicant with good respiratory effort. So generally it is done if the patient is intact mental sensorium, able to generate good respiratory effort and all, and he was able to generate the is patient able to just expected to wean off or something, then you put them on pressure support ventilation. So by now we learned 3 modes: assist control, synchronized intermittent mandatory ventilation, and pressure support ventilation. Assist control, completely it's ventilator control. The patient does not need to do anything. If he generates breaths also, ventilator will support. So initial stage of ventilation, you need to use this, and the patient is altered sensorium or not able to generate spontaneous breaths, you need to use this ventilator support. So synchronized intermittent mandatory ventilation, in them, like whatever set rate you are putting in them, that breaths will be generated by the mechanical ventilation. Whatever extra breaths patient is doing spontaneously, those won't be supported by ventilator. Those extra breaths will needs to be depends upon the patient's effort. So there is a risk of hypoventilation in this case. So see, you can convert to AC SIMV when the patient spontaneous breaths are good, respiratory efforts is good, and slowly when you are converting, the patient is recovering in that patient, AC to SIMV you convert. So pressure support, when you use, generally in them only 2 settings are there. One is PEEP and FiO2. PEEP is just to put the alveoli inflated, so to decrease the respiratory effort. FiO2 to deliver the oxygen. So you need to put them in, especially when the patient is on about to wean off or something. There is good respiratory effort. Patient is completely conscious and all, and doesn't require any invasive ventilation or something. You need to put them on pressure support ventilation. You put a basic of PEEP or FiO2 or PEEP or 5 or something, and FiO2 based on the SpO2 you can monitor and put. So these are the generally SIMV. In SIMV you also put pressure support ventilation. So generally why you put pressure support in the case of SIMV patients is because because the patient, whatever breath he is taking, like patient, that is not completely depends on the patient effort. So if you give some amount of pressure support to that patient, let's say you are giving a pressure support of 5 to 6 or something, that will decrease that will help the patient's effort. So you can put pressure support to the SIMV patient so that it will help the patient. So this is you need to question whether you put volume targeted or pressure target. Most of the adult patient require volume targeted only. AC and SIMV. AC is initial stage when the patient is not in conscious or something, when there are no spontaneous breaths. SIMV, when there are spontaneous breath, patient is slowly recovering, he was able to generate enough effort and all. And in the SIMV, if the patient effort is not good enough, you can add pressure support also. A minimum of a patient pressure support will help in patient's effort in breathing. So what volumes do you want, what respiratory you want, what PEEP you want, what FiO2 you want, we'll discuss in the later slides. So what tidal volume we should start with? Generally, for 8 ml per kg, ideal body weight is what we advise in the patients, in most of the patients. It is ideal body weight. What is ideal body weight? You let me know. And it should not be more than 10 ml per kg ideal body weight. So generally you want a lower tidal volume, especially in the case of status asthmaticus or ARDS and acute lung injury patients. So in all these acute lung injury ARDS patients, they generate low tidal volume. That is around 6 ml per kg ideal body weight, what we advise. Generally you start with 8 and go to 6 or something. So especially ARDS, status asthma, ALI, in all of these patients, generally you advise a lower tidal volume around 6 ml per kg ideal body weight. So these are in the pressure support, that ideal volume depends upon the whatever pressure you set the target. So how much respiratory rate you should start with? Generally, you should check the patient's pre-intubation rate. Let's say patient pre-intubation rate is around 30 or something. You keep 2/3 of it. Let's say 20 or something, you keep it. Generally, that is what you advise in the case of respiratory. If the patient is breathing at 32 breaths per minute, you keep it at 14. And remaining ventilations are all hypoventilation. Patient is putting more effort to generate ventilation. So generally you put 2/3 of it. So that is what you generally keep. But especially in the case of sepsis or ARDS or metabolic acidosis, there where there is high respiratory rate, generally higher rates are required, because the patient is compensating. Is like in the case of metabolic acidosis, he was able to he was increasing respiratory rate to wash out the CO2 or something. So in that patients you might require higher respiratory rates, especially in the case of ARDS and metabolic acidosis. You need to put them on higher respiratory rates. If you don't put them on, the set rate is not high, remaining breaths won't be supported sometimes in the case of SIMV or something. So patient might be hypoventilating in those patients. So minute ventilation will decrease. So that is why in the case of sepsis or ARDS and metabolic acidosis, whatever pre-intubation rate is there, calculate 2/3, put them on the little higher respiratory rate, so that whatever breaths he was able to, like spontaneous breaths are there, they are also really supported. So especially in the case of status asthmaticus, you use lower respiratory rate. Why we use in the case of lower respiratory rate in the case of status asthmaticus is because if you increase the respiratory rate in the case of status, let's say asthma patient is there, you increase the respiratory rate, what will happen? Respiratory rate will increase, it will decrease the expiratory time. If you are giving more respiratory rate is occurring, let's say 20 breaths per minute is occurring, the expiration time will decrease. So expiration time is decreasing, what will happen? Because there is already obstruction at the airway, so expiration time is also decreasing. So it won't give enough time for the whatever tidal volume you are inspiring to expire out. So what will it cause? It causes auto PEEP. So it will cause auto PEEP, it will cause hypoventilation more, because there is auto PEEP, there is already end expiratory pressure because of the insufficient clearance of the whatever tidal volume we are inspiring. So it will cause auto PEEP generation, it causes hypoventilation. So that is why in the case of status asthmaticus we generally prefer lower respiratory rate, so that it will give enough time for the lungs to expire out the lungs in the already existing obstructive lung disease. So that depends upon the inspiratory time and expiratory time. So this is the minute volume, that depends upon the respiratory rate and tidal volume. So if you decrease one or both, they will decrease the minute volume. Minute volume decrease will cause hypercapnia. So you need to keep this in mind. So generally in the case of ARDS, we generally keep low tidal volume. Respiratory rate generally in the case of sepsis and ARDS, we keep it on the higher rate, so that you put in enough minute volume, and there is a permissive hypercapnia. So generally you maintain the pH around 7.25 or something. There is a permissive hypercapnia is generally allowed in the case of ARDS patients. So in the status asthma also there is permissive hypercapnia is generally allowed. So in the case of status asthmatic, you need to put low tidal volume also, and also you put low respiratory rate also to prevent the auto PEEP. So I explained already phenomenon behind the auto PEEP and all. So this is the thing. Permissive hypercapnia is generally allowed in the case of ARDS. So you generate put a minute volume depends upon the respiratory and tidal volume. So what PEEP should be start with? Generally we start a PEEP of 5. So PEEP is to keep the alveoli inflated. That is the main thing. In the case of big patients or something, you can go to PEEP of 8 or something. But to improve the oxygenation, let's say you are increasing FiO2 is already maximum, but you need to improve the SpO2 more. Then you can increase the PEEP by increments of 2 or something and then see. But if you increase the PEEP, it increases the positive and expiratory pressure. It also increases the intrathoracic pressure. So it also decreases the venous return. So it might cause fall in BP, that you need to keep in mind when you are increasing the PEEP. So increase the PEEP more, it will cause more fall in BP. Especially this is more important in the case of pulmonary embolism. So what will happen in pulmonary embolism? There is already right heart failure. So right heart failure is dependent on preload, whatever volume. Especially in the case of right ventricular MI or something, what is the primary role of treatment? What is the primary management of treatment in the case of right ventricular MI is giving enough volume. So right ventricle is dependent on volume. So in the case of acute pulmonary embolism, there is already right heart failure. So in the right heart failure, treatment is mainly to give enough volume so that right heart failure will contract better. So in the case of you give more PEEP in the pulmonary embolism patients, what will happen? The preload will decrease. If the preload will decrease, the right ventricle fail more. So that is why in the case of, especially in the case of pulmonary embolism patient, you don't go for high PEEPs and all. So that is why. So if you keep the ventilation, generally you don't advise ventilation only in the case of pulmonary thromboembolism, because there is no point of ventilating such patient. If you put them on ventilation also, don't put them on high PEEP, because high PEEP will decrease the venous return. Venous return will further excavate the whatever right ventricular failure is there. So in the case of pulmonary embolism, if you put them on ventilator, closely monitor blood pressure, because there are chance of low BP, because if the mechanical ventilation will increase the intrathoracic pressure and will decrease the venous return, because right ventricle will depends upon the preload for its failure. So what FiO2 should I start with? So generally start with 100%, and then based on the SpO2, you need to titrate upwards and downwards. What flow rate? Generally we keep a flow rate of 60 L per minute. Maybe especially in the case of air hunger patients or asthmatic patient, you need to go for 80 ml per minute or something. So that is the flow rate. So alarms, there are resistance alarms, different thing. So I already told you increase in P peak is generally seen in the case of upper airway obstruction. So any kinking of tube or any upper airway obstruction, any bronchospasm, any mucus plug or something, what increase the P peak. So generally P plateau is generally increase in the case of any ARDS, or there is a alveolar compliance issue. So ARDS or pulmonary edema or fibrosis, that will increase. So generally if the patient is like sometimes the patient is respirating like let's say is at the rate of let the patient is a let the patient is in mechanical ventilation, you set the rate of 16 breaths per minute, but patient breathing at 24 breaths per minute, but patient is hypoventilating, you are not able to, the patient whatever condition is not recovering and all. So first thing you need to do is you check for any if the FiO2 and PEEP are normal or not. If FiO2 and PEEP are apt to the point, so you need the set one right, there is no hypercapnia, you need not alter respiratory rate or tidal volume. Then you check for any blocks are there, any P peak and P plateau you check, any mucus plugs are there, any kinking of tube is there, any bronchospasm is there, you check. Then you check for next thing, you check for any auto PEEP is there. How you check auto PEEP? I'll put a case based scenario. Then next thing is you need to sedate the patient. So generally what will happen is if the patient is like let's say patient is in ARDS or something, he'll obviously in tachypneic. If you put them on ventilator, the tachypnea will continue again, but whatever breathing he is taking, it is not generating enough minute ventilation because tidal volumes are low in them. So patient is going to respiratory fatigue because of that, it will worsen the condition more. So it is better to sedate those patients. So it is better to sedate those patients with, first you sedate them with midazolam or opiates, fentanyl or something, you need to sedate those patients. If still patient is not improving with sedation also, you need to give neuromuscular blockade, that can be atracurium or cisatracurium or vecuronium, whatever. I'll make a separate topic on sedation and neuromuscular blockade and mechanical ventilation. But if the patient is having respiratory synchrony, because like let's say the patient is the ventilator is delivering the breaths, in between he is also taking breath, it will cause ventricular, there is asynchrony between the ventilation, there is patient and mechanical ventilator asynchrony is there. So it is better to sedate those patients who are breathing more or the tidal volumes are not generating properly. It is better to sedate the patient, put them on completely assist control mode for few time till the patient condition recovers. So that is sedation. Always try to put boluses first, then go for drip. Always bolus are preferred over drips sometimes. So generally paralysis without sedation is a torture. Always sedate first, then go for neuromuscular blockade. Don't prolong the sedation and neuromuscular blockade more than 48 hours. It leads to respiratory muscle paralysis. Keep it short until the patient recovers and all. Keep it short. So what are the record? This is all regarding invasive ventilation. We discussed about tidal volume. We discussed about respiratory rate. We discussed about the I by E ratio. We discussed about the what is the flow rate. We discussed about the previously we discussed about sedation and delivery, sedation and also. Now we discuss about the non-invasive ventilation. Generally, non-invasive ventilation is the preferred ventilation, especially in the case of COPD patient, or any asthma exacerbation is there, or any pulmonary edema is there, initial stages of ARDS something. So in them, non-invasive ventilation is there. In them, we have CPAP and BiPAP. So what is CPAP? CPAP is continuous positive airway pressure. So it generally puts a continuous pressure. What is BiPAP? There is a positive airway pressure. That is both inspiratory and expiratory. In the CPAP, only continuous pressure is only set, only constant pressure is delivered along the inspiration and expiration. That is set by PEEP, that is pressure support, whatever we are giving, that is continuously delivered in entire breath. In the case of BiPAP, inspiration level is different from the expiratory level. Let's say we set an inspiratory level of 20 or something, expiratory level we kept at 5. So there is a difference in pressure. So that difference is pressure support what we are giving. So that is the difference between BiPAP and CPAP. So CPAP there is a constant pressure throughout the breath, whereas BiPAP there is a bi-level pressure. So the inspiratory pressure generally is 8 to 10 and the expiratory pressure 3 to 4. The difference between them is pressure support ventilation. So we generally monitor them every 4 to 6 hourly based on the ABG and something, ABG and all, and also based on the respiratory rate, what is the sensorium. We generally, and use of axillary muscles and all, heart rate. Based on that, we can generate the inspiratory pressure and expiratory pressure. You can increase or decrease. So these are the CPAP. Initially we start with cardiogenic pulmonary edema where you increase the PEEP. So PEEP will cause the, so when there is a, when you increase the PEEP, it will cause alveolar dilation that causes the decrease the interstitial, it causes the clearance of the interstitial fluid whatever is there. So especially in the case of CPAP, we have only two settings. One is FiO2, one is PEEP. So PEEP you keep it around 5 or 6 or something. FiO2 based on the oxygen requirement you can keep. So it will cause clearance of pulmonary edema, whatever is there. Initial stages of COPD also in hypercapnia with respiratory compensated stages we can put by CPAP, compensated especially. And OSA patient also, obesity hypoventilation, there is hypoventilation per se, there is no CO2 narcos and all, in them you can put CPAP. So when there is compensated respiratory acidosis or there is no only OSA, there is only hypoventilation per se, in them you can put CPAP. But there is significant acidosis and all, there is a hypercapnia, the pH is less than 7.35 is there, in them especially you suggest BiPAP, so that will help in better clearance of CO2 and better correction of acidosis. So when you want to correct the hypercapnia better, if you want to correct the acidosis better, BiPAP is always an option. Only when there is compensated is there, only hypoventilation is a problem and only pulmonary edema is a problem, CPAP is a better option. So this is the thing. In inspiratory pressure CPAP you keep only PEEP and FiO2. In BiPAP you generally start with around PEEP of 5 or something and inspiratory pressure around 14 or something, and based on the CO2 clearance and all and oxygenation and all, you can change the values to 16.8 or 14.6, that inspiratory pressure of 14 and expiratory pressure of 6, or inspiratory pressure of 16 and expiratory pressure of 8 or something. You can change based on the CO2 clearance and pH. So what are the problems during inspiration? Hypoxia, it is corrected by FiO2 and PEEP as I mentioned. If there is sudden drop in oxygenation, you should always look for any pulmonary embolism, is there any tube blockade, is there any pneumothorax, is there any sudden collapse of the lung, is there any mucus flux in the tracheal tube, is there in IT tube, is there, that all needs to be checked. Mainly oxygenation depends upon PEEP and FiO2. Hypercapnia, as I mentioned, it depends on the respiratory rate and tidal volume. So, but while increasing the respiratory rate, always look into the auto PEEP, especially in the case of obstructive lung diseases, COPD and asthma. Elevated pressures, two pressure, P peak and P plateau, already mentioned. P peak is mainly dependent on tubing and bronchial tree. P plateau is the lung compliance. So P peak, kinking out tube, blocking of ET tube or bronchospasm. P plateau is pneumothorax, atelectasis, pulmonary edema, ARDS. So this is auto PEEP. What is the auto PEEP? So inhaled air is not fully exhaled at the end of respiratory cycle. So the accumulated trapped air will increase the pulmonary pressure and cause barotrauma and hypotension. So whatever inhaled air which is not completely exhaled out, so whatever in that what is trapped air is there, that causes increase in pressure, that causes barotrauma, it increases the intrathoracic pressure and also causes hypoventilation and hypotension. So patient will be difficult to ventilate because already there is existing air that is not washed out properly. So it will be difficult to take one more breath again. So to prevent and resolve this auto PEEP, so first thing is to decrease the inspiration to expiration ratio. So decrease the inspiration to expiration ratio. Let's say initially you kept it 1:1 or 1:1.5, decrease it to 1:2, which is physiological. So normal physiological is 1:2, expiration is more. So in them decrease it to 1:1.5 or 1:1 or 1 or something. You give more time to expire or something. That is the primary thing. Also decrease the respiratory rate and decrease the tidal volume also. One more thing, if you suspect any bronchospasm is there, so adequate bronchodilation and steroids also needs to be given, especially in the case of COPD and asthma patients. And adequate sedation also needs to be given. Because adequate sedation, why we are giving? Because in case of if the patient are not sedated, they generate lot of spontaneous breaths. So it won't give enough time for expiration and all. So if you sedate the patient, no spontaneous breaths will be there. Whatever mandatory ventilation set rate we are giving, that only will be delivered. So tachypnea also sometimes, excessive spontaneous breaths also sometimes can generate auto PEEP. Because of that, we won't be able to deliver whatever tidal volume and FiO2 we want to deliver. So patient will have hypoxia, hypoventilation, hypotension and all. So that is called, or tachypnea, excessive spontaneous breaths also will cause auto PEEP. That's why you need to sedate that patients. So if the patient is causing severe hypertension, disconnect the ventilator. So patient ventilator desynchrony. So this is one more thing I mentioned about. So this might be due to hypoxia or auto PEEP or whatever is telling. So the patient so because of the auto PEEP or excessive spontaneous breaths and excessive tachypnea or something, we are not able to correct the whatever acidosis or whatever hypoxemia is there, we are not able to correct. So after ruling all other causes I told you, auto PEEP, P peak, P plateau, hypoxia, hypercapnia, all correcting them, put them on sedation. If there is a patient ventilator desynchrony is there. First sedation, then neuromuscular blockade. So these are the mechanical ventilation asthma. Earlyly use non-invasive pressure support ventilation. Permissive hypercapnia is allowed. So low tidal volume, low respiratory rate. Why I mentioned low tidal volume, low respiratory I mentioned. Why? Because it will prevent the auto PEEP. So it will give enough time to expire the air out so that you can ventilate the lung better, you can wash out the CO2 better and all those things. high flow rates, more than 80 or something. Low tidal volume is 6 ml per minute, low respiratory around 6 to 8 breaths per minute is enough in the case of asthma patients. In the case of tidal volume 6 to 7 ml, breaths rate around 8 to 10, 80 to, this is the settings in the asthma patient especially. Flow rate is 80 to 100 ml per minute, sedation if required. Expect high peak pressure because generally because the asthma level is at the bronchial asthma, it is due to the constriction of the upper airways, so high peak pressures might be present. High plateau pressures is also present if the alveoli, there is a constriction of bronchioli and at the respiratory bronchial level is also there. So auto PEEP should be monitored regularly. If the high plateau pressures are there, high peak pressure is there, if there is insufficient clearance of tidal volume after inspiration, always suspect auto PEEP. So ARDS, lung protective strategy, always go for low tidal volumes and low plateau pressures, permissive hypercapnia. You can go for high PEEP in these patients. Low tidal volume, high PEEP. So you can go for permissive hypercapnia, around pH can be maintained at 7.25 or something. So now questions. So patient was recently intubated, set on synchronized intermittent mandatory ventilation. Tidal volume is 490 ml per minute. Respiratory rate is 12 breaths per minute. PP is 5. FiO2 is 100. Breathing is 28 breaths per minute. So patient looks incredibly uncomfortable and patient oxygenation is 93% and exhaled carbon dioxide is 35. What is the next step? So whether you paralyze the patient or increase the PEEP or increase the tidal volume or sedate the patient or add pressure support. So let's say if the patient is on SIMV, tidal volume is 490. Already tidal volume is at like almost at the upper limit or normal. Respiratory rate is 12. PP is 5. So PP is 5. FiO2 is 100. So breathing is 28 breaths per minute. He is already breathing more. So we set a respiratory rate is 12. He is having spontaneous breath of 28 breaths per minute. So he is breathing more. So what is the next step? So paralyze the patient. Don't do unless generally you go, the paralysis is the last step you need to do. After ruling out all the causes, you need to do paralyze the patient. Increase the PEEP. Generally our target of ICU is generally more than 92 is enough. 88 to 92 is enough in the case of them. Generally more than 90 is enough. So we need not increase the PEEP in this patient because 93% saturation is good enough in this patient. Increase the tidal volume. Tidal ventilation is okay. It's not bad also. Tidal volume is already as the upper limit. You need not increase the tidal volume in this patient. So paralyze, always after sedation only we need to paralyze. Sedate the patient, maybe it is a good in this patient because why? Because there is already excessive breath rate is there and patient is having discomfort and all. So maybe you can try sedating this patient. So because there are a lot of spontaneous breaths and respiratory set rate is only 12. It is on synchronized intermittent mandatory ventilation. Sometimes patient has to put in more effort for the extra 16 breaths whatever he is doing. So sedation may be tried in this patient. So before sedating the patient, one thing we can try is we can give pressure support this patient. So this extra 16 breaths, whatever extra spontaneous breath, you can support these breaths in that patient. If still patient is uncomfortable after pressure support also, then you might need to sedate that patient. So you need to give pressure support in this patient so that 16 breaths water patient is generated, which is against the tubing and against the resistance. You might add some help to the patient's breath effort. So if the patient is still not able to tolerate after pressure support also, you might need to sedate this patient. Scenario 2. Patient was recently intubated. He was put on assist control. Tidal volume is 600 ml. Respiratory rate is 18. PP is 5. FiO2 is 100. Breath is 28. Same spontaneous breaths are more. So if set rate is 18 and breaths are more, that means there is spontaneous breaths are present. And ABG tells you pH is 7.65. There is alkalosis definitely. CO2 is 12. Oxygenation is more. 400 is there. Bicarb is 24. So 98% oxygen is there. What's need to be done? Do you increase PEEP? Oxygenation is already better. No need to increase the PEEP. You need to decrease the respiratory rate. Whether you decrease the respiratory rate or not, I'll tell you. Increase tidal volume. 400 ml is there. Whether you give bicarb, already alcohol is there. You definitely don't give bicarb. Or you decrease the tidal volume. So first thing you might think is there is alcohol per se. We are washing out CO2 more, so we will decrease the respiratory or decrease the tidal volume because CO2 is washing out more. No, you might have thought we'll decrease tidal volume or respiratory rate. What is the next thing? I'll tell you. So increase PEEP. Patient oxygenation is definitely good, 98%. FiO2 is also more. In fact, you have to decrease the PEEP actually in this patient. Decrease the respiratory, most common error in this patient. Why I will tell you. Tidal volume, don't increase that alone. Already it is very high, 600 ml is present. So bicarb, already alkalotic, you need not give bicarb. So decreased tidal volume already at maximum 600 ml, you calculate it based on, set it around 8 cc per kg or something. 6 to 8 is good. Maybe if the more than 10 cc you can decrease the tidal volume, but definitely not increase. So But what is the choice in this patient is we might need to sedate this patient in this case. So because whatever respiratory rate 18 are giving, breath rate is 28. If you decrease the respiratory set rate more, whatever breaths he is taking, so 28. So they will most of the, like if you decrease the respiratory rate 18 to 28, so 10 breaths are unsupported in this patient because patient is on assist control. If you decrease the breaths more, so these breaths are not patient generated. So if you decrease the respiratory rate more, what will happen is like if you are decreasing, the patient is breathing more, spontaneous breaths are more, you are not supporting that ventilation. So there is no point. The patient is already breathing more. There is no point of decreasing the respiratory rate per se. So what is better in this patient? Because he is hyperventilating, he is going into alkalosis because of the CO2 washout. If you decrease the respiratory rate also, because spontaneous breaths are there is no point of decreasing the respiratory rate in this patient. So what you need to do in this patient is sedate the patient. Because if you sedate the patient, respiratory rate, obviously spontaneous breath will decrease. So whatever set rate is there, that will only be delivered. So that is the better thing in this patient, is to sedate the patient to correct the respiratory alkalosis in this patient. So the respiratory alkalosis is one of the most common complications you see in the case of assist control ventilation because of the excessive minute ventilation, because spontaneous breaths are coming, your mechanical ventilation set rate is there. So respiratory alkalosis is a common component in this patient. So why not decrease respiratory? I again tell you again, if you decrease the respiratory rate also, the spontaneous breaths are anyways there. So you'll obviously hyperventilate. There is no point of decreasing the respiratory rate. So, and anyways in the assist control ventilation, they will all be supported. So it is better to sedate the patient and decrease the spontaneous breaths itself, so that it will decrease the excessive tachypnea and excessive minute ventilation, and the respiratory alkalosis will be corrected. So this is a common complication in the case of assist control ventilation. So a 55-year-old male patient with an ideal body weight of 70 kg has been rushed to emergency room. He was found to be unresponsive and apneic. So this decision is made to intubate the patient and mechanically ventilate. The patient was put on assist control with volume control, and also tidal volume of 500 ml, and also respiratory rate is 815 breath. This is a set rate. Positive and expiratory pressure is 5 centimeters of H2O, and FiO2 of 100. Flow rate is 760 liters per minute. So pH is 7.30, and PCO2 is 55, and arterial oxygen is 310. So what do you do in this patient? So definitely there is some amount of acidosis present. pH is lower side. PCO2, some amount of CO2 retention is there. PO2 is also higher side. What do you do in this patient? So this is an assist control ventilation. Tidal volume is 500 ml per minute. So generally for 18 to 10 into 70, 700 ml. So 8 is around 8 7 56, 560 ml. So respiratory is 15 breaths per minute. PP is 5. So what do you do in this patient? So first thing is PaO2 is on the higher side. So first you need to decrease the PaO2. So you decrease the FiO2 and PEEP in this patient. So maybe you can decrease the PEEP by 1 or 2, like 4 or something. Generally 5 is preferred, it is already on the lower side. You can decrease the FiO2 in this patient because PaO2 is on the higher side. Next, for CO2 washout, you need to increase the respiratory rate. That you can make it 15 to 16 or 16 to 18 something you can keep. Tidal volume also you can increase in this patient. Let's say because 8 ml per kg will come around 560 ml or something in this patient because of the ideal body weight. So you can increase the tidal volume and respiratory rate in this patient for the CO2 washout. But while you increase in the respiratory rate and tidal volume, always keep auto PEEP in the mind. Next is auto PEEP. I'll tell you what is auto PEEP. So in this patient, you decrease the PEEP and you decrease FiO2 mainly, and then decrease the PEEP, then increase the tidal volume and respiratory rate in this patient. So next thing, you receive your patient at the start of your shift. This is the case 4. They are intubated and put on the pressure control ventilation. Ventilator settings are respiratory rate is 20 beats per minute, pressure control is 16 centimeter, and inspirator time is 1 second, and PEEP is 10 centimeters, and FiO2 is 0.4. So when you give your when you ask for ABG, in ABG 7.47 pH is there. So PCO2 is 38, and PO2 is 115, and bicarb is 30. So there is definitely alkalosis, both metabolic alkalosis is there, respiratory alkalosis both are there. So what do you do in these patients? So there is alkalosis definitely. So you need to retain the CO2 more. So in this patient, you decrease the respiratory rate. So in order to decrease the tidal volume, there is no tidal volume in this patient. So to decrease the tidal volume, you decrease the pressure support. Whatever pressure control is there, you need to decrease the pressure control also in this patient. So you decrease the respiratory rate to preserve more CO2, and also to correct the alkalosis whatever there. If you decrease the pressure control, the tidal volume will obviously decrease. If the pressure, whatever set pressure you are decreasing, if pressure decreases, tidal volume also decreases. So you decrease both of them. and here 115 is there, little bit over oxygenation is there, you can decrease the PEEP in this patient. FiO2 is already low, you can decrease the PEEP in this patient to around 8 or something, that will do the job. So you will correct the both whatever alkalosis is there and also excessive oxygenation will also be corrected. You decrease respiratory rate and pressure control in this patient. So a COPD patient is put on the ventilator, you found this on ventilator. So what is this? So you can see in this patient, he was not able to completely exhale out. There is some amount of breath is already remained, that is that this gap is auto PEEP. So whatever gap this is there is auto PEEP. He was not able to completely exhale it. Generally it will come back to flat line again. Whatever this is come back to flat line again and again generate the breath. But here inspiration effect is again occurring at the before the end of expiration. This is the auto PEEP. So the extra volume which is being retained at the end of expiration will generate the pressure, that is called auto PEEP. This will cause hypoventilation, increase the intrathoracic pressure. You cannot even see in this patient there is oxygenation is low in this patient. He was not able to P peak is also increased, then the P plateau also will increase in this patient. So this is the auto PEEP in this patient. So this auto PEEP, what you do in this patient? You decrease the respiratory rate, decrease the IE ratio. You make IE ratio from 1:1 or 1:1 or 1:1.5 you put on, increase it to 1:2. Here IE to ratio 1:1.1. You increase it to 1:2 or 1:1.8 or something. So it will give better time for the expiration. So you decrease the respiratory rate also in this patient. If possible, if still not possible, if there is any bronchospasm or something, you can need to give bronchodilator and steroids also in this patient. If still not possible, you need to sedate the patient. So this is the auto PEEP. So if you find this in graph, before the end of expiration only inspiration is starting this is the suggest of auto PEEP, this extra gap. So this is no air trapping is there. Generally it will come back to normal phase and again start again. The loop will start again at the end of, it will come to flat again, the baseline and again start. In the case of air trapping, it will start before only. Before coming to baseline only it will start. So this is the difference. Before the baseline only inspiration is starting here. So this is the extra is called air trapping, auto PEEP. So auto PEEP, progressive air trapping, it increases the pulmonary alveolar pressure. Intensity will happen when there is incomplete exhalation of the breath. So suspect when the flow on the ventilator does not go back to zero. So here you can say does not go back to zero. Suspect it when it is there. So what do? It increases the intrathoracic pressure, it causes barotrauma and decreases the venous pressure and cause hypotension. It causes hypoventilation also. There is discomfort and also is there. So decrease the airway resistance, bronchodilator and increase the flow rate, decrease the IE ratio and decrease the respiratory rate. So decrease the overall minute ventilation. If there is acute hypotension is, you can decrease. So this is the thing. So allow enough time for the expiration. So if you don't allow enough time, if you give here only, so next breath will happen, it causes auto PEEP. So this is the thing. Thank you.